Good morning. My name is Jeff Weigel, and I am an epidemiologist and the epidemiology program manager for Panhandle Health District 1, which is the 5 northern counties of North Idaho, serving a little over 264,000 people. And we will be talking today about substance use disorder and how epidemiologists can affect this. There's my disclosure. So what is epidemiology? This may be a review for some people. I will go over it again though. Epidemiology is the study of distribution and determinants of health-related states or events in specified population. And the application of this study is to control health problems. We ask, why did they get it? Meaning the disease or pathogen. How do we stop it? Whereas clinicians are concerned about the health of an individual, epidemiologists are concerned about the collective health of the community. There are 2 types of epidemiology. There is descriptive and analytical. Descriptive epidemiology asks when, where, who, and what, so the time, place, person, and condition. They make hypotheses based on risk factors and causes of disease. They rely on pre-existing data, mainly from primary research sources and peer-reviewed data. It uses groups or individuals of people. They highlight and refer to individual case reports, case series, incident and prevalence cases and rates. And in research epidemiologists specifically refer to studies that involve cross-sectional studies. And that the descriptive epidemiology illustrates potential associations. Analytical epidemiology discusses the how and why the disease occurs. Analytical epidemiology is concerned with the search for causes and effects. It uses the information collected from individuals rather from the aggregate population, which descriptive epidemiology does. It focuses on risk factors and causes, and it analyzes the distribution of exposures and diseases. And it relies on the development of new data, specifically in surveillance activities or in clinical trial studies. And it evaluates the cause and associations of those. There are many different types of concentrations of epidemiology. I will discuss several, or showcase several, but there are 2 or 3 dozen different specific areas of epidemiology. There is cancer epidemiology, cardiovascular, which is a part of epidemiology to discover the source, because especially within substance use disorders, individuals have a tendency to not take care of themselves. They don't exercise. They eat fatty foods, especially when they're consuming alcohol. And they generally don't take care of their personal hygiene. They don't brush their teeth. And we know that periodontal disease can lead to cardiovascular complications later on. Clinical epidemiology, also known as hospital epidemiology or infectious disease control. Environmental and occupational, genetic epidemiology. Infectious disease epis are generally most epidemiologists that work in local health districts, state health departments are generally considered infectious and communicable disease epidemiologists. But we all generally have one area within epidemiology that we like to focus. Neuropsychiatric epidemiology, nutritional, molecular epidemiology, which is my niche that I like to study, pharmacoepidemiology, reproductive, perinatal and pediatric, and substance use disorders, SUD epidemiology. So an epidemiologist with substance abuse disorders primarily look at trends and data. So they'll look at peaks and valleys, just as you had with COVID, where it showed the high points and the low points to make it indicative of a higher transmission or higher prevalence of that specific pathogen in the environment. We do the same with substance use, particularly by tracking overdoses and deaths. We look at the demographics, the demographic prevalence, so the age, socioeconomic group, their race, gender. We'll use geographic prevalence and trends. This is important to have on a map to notice certain clusters of which may be considered an outbreak of overdose deaths, particularly now with the prevalence of fentanyl being mixed in and laced within synthetic opioids and even marijuana. If we notice that it's in a specific geographic area, we may reach out to law enforcement, the DEA, because the dealer may be located in that specific area because they have a tendency to distribute within their home area. That may be something, and oftentimes law enforcement knows about them already. So we may be able to talk with them, and hopefully they can mitigate that and abate. We have to consider comorbidities, specifically co-occurring mental disorders, which almost always occurs with substance use disorder because substance use is often used as a coping mechanism for their untreated mental health illness. We look at phenotypic presentation, so the nature-nurture discussion. There has been, for years now, they've identified a specific gene that codes for a propensity for addictive behavior in offspring. And they originally predicted that it would be about a 50-50 mix of you have a genetic predisposition at your first drug usage or sip of alcohol, you have a higher prevalence of developing that as an addiction. There are many caveats or confounding factors to that, and most of those deal with the environment in which they're raised in. Childhood trauma, so their ACEs score, if that is high. Generally, it's the input or the environment that they've had presented to them in their adolescent years, which are now indicated up to age 23. We look at the sources. We don't have much effect at a public health level on implicating or inducing mitigation strategies for that. That's mostly done by the federal government, federal law enforcement. So the sources coming from out of the country, drug runners. During the COVID pandemic, there were the sources, the supply of drugs was abated because of interstate transportation, a lack of interstate transportation, lockdowns in some states. So because of this, it's hypothesized, actually it's not hypothesized, it is known that drug dealers have started to use fentanyl and carfentanil to make their drugs last longer, the raw product last longer. But where we can make an effect in public health is by decreasing the demand. And that's basically by getting resources to people who do have this disease that they can get into treatment centers, or they can get on court diversionary programs. And we have multiple mitigation strategies to prevent the diseases that come from substance abuse. And we develop relationships with community and stakeholders, so with local mental health treatment centers, substance abuse centers, with government officials, with law enforcement, with other health jurisdictions across the border or within the state, or transcontinental, or rather trans country lines, so like with Canada. And we use this to search for explanations and hypotheses that we can gather from this. So substance use, you'll see this is from 2019. Because of the COVID pandemic, there have been some lags in catching up statistical data because of COVID. A lot of health care professionals and public health officials were diverted from their regular fields of study to focus on containing the COVID spread. So this is a chart that shows the majority of people that were asked, 12 and older, in the last month, what they had used. And you can see the vast majority are alcohol, followed by tobacco, and then marijuana. And you see that we have kratom up there, which is also called Mydagenia speciosa, and it comes from a native tree species in Southeast Asia. And its products are derived from its leaves, and it's marketed as a supplement. It's not approved by the FDA, and it can be bought in gas stations because it's marked as a supplement, herbal supplement. But it's known as bioactive alkaloids that can affect the body. So we see that 60% use tobacco, alcohol, kratom, and another illicit drug or other illicit drug in the past month. Almost 51% had consumed alcohol. 21% used tobacco products. 13% used a different illicit drug. 0.3% used the kratom. Overdose deaths were increased during COVID's first year of 2020. Almost 100,000 people died because of drug overdose. 29% increase, and 75% of those deaths involve synthetic opioids. There are many hypotheses on why this happened. A lot of it was isolation. A lot can be determined because of the increased stress of having a novel pathogen that is killing people. So that may be their coping mechanisms. And also, because of isolation, they may be holed up in their house and not have a friend or family member that could call 911 or administer naloxone when they overdose. These are the opioid overdose rate for Panhandle District since 2017. Now this is the rate per 10,000 hospital seen in the hospital, in the emergency department. So not the general population. And we see that increase coming up right around the time of COVID, 2020. This is the opioid overdose report, which also includes deaths and fatalities. And we also see, if we're looking at 2020, we see 14 in March when the pandemic was declared. Binge drinking and alcohol, age 12 and older, this was from 2019. And this shows the amount of alcohol users and those who that are binge drinkers. So diseases that result from maladaptive substance use, and I use this phrase as opposed to substance use disorder, because this doesn't have to be a pathological situation in order for these diseases to develop, especially with STIs. So it can diminish the immune system function and provide an opportunity for infection, cause cardiovascular problems, which we talked about before, gastrointestinal issues, so it can cause, if there is liver disease, it can cause portal hypertension, thus them developing esophageal varices, which somebody can vomit their blood volume rather quickly and die. Respiratory problems generally comes from tobacco inhalation, smoking methamphetamine, smoking cocaine, smoking heroin. Liver damage, hepatitis C is the most prevalent, but also A and B because of poor hygiene, since those two are generally fecal to oral. Kidney damage. Neurological issues, specifically with alcohol consumption, Korsakoff syndrome, which is a vitamin B1 deficiency, and it affects their brains. And then the bloodborne pathogens, Mainly the one for this is hepatitis C, and sexually transmitted infections is the largest ones that we study because they are the most reported of the reported diseases, which are 81 in the state that are reportable to public health. These by far are the most prevalent. So chlamydia, gonorrhea, syphilis, and congenital syphilis specifically. Chlamydia has actually gone down by 1.2% from 2016, which is surprising because by far this is the most common reportable disease that I see on my list from the National Disease Reporting System every day. Gonorrhea is next. That is up 45% from 2016. And resistant gonorrhea is actually gone up quite a bit from there. And some studies, some predictions have said that it's expected to reach about 50-50 of the uncomplicated gonorrhea to the disease-resistant or antibiotic-resistant gonorrhea. Syphilis cases are on the rise everywhere across the country, including the Panhandle District. Across the country, they're up 52% from 2016. And a lot of this is determined, and it's gone up from 2021 and 2022, we're seeing higher cases. A lot of it is because their lack of access to medical attention for other ailments during the COVID crisis. And a lot of them are seen for non-primary syphilis. They're seen for secondary or neurosyphilis or tertiary because they see in primary syphilis, they'll see a lesion on their genitalia, and it goes away quickly. They're like, oh, that was really nothing. Well, actually, it's because it's progressed to secondary syphilis, and they will see rashes and bumps come up on the palms of their feet or the bottom of their feet or the palms of their hands. And then congenital syphilis is the concerning one because that is up 235%. And I've heard some estimates say that it's up to 460%. And this caused some guideline change in December of 2020, which are the 2021 treatment guidelines. And that also had to do with increased testing for STIs and hepatitis for prenatal women. This is the syphilis, treponema pallidum spirae. So the primary rates The rates of primary and secondary syphilis continue to increase in the United States. Rates of both primary and secondary increase both in men and women, a little bit higher than in men. The rates among women, though, increased 36.2%, and the rates in men increased by 88.7%. And this 2021 primary and secondary syphilis data reflects a surveillance system, the Notifiable Disease Surveillance System, and this is updated as of March 9th, 2020. This is a graph that shows the infants who were born with cases of congenital syphilis. And 7% of all of these resulted in stillbirth or prenatal death. And it also includes in that graph the ones who are untreated will have maladies in their bones, born blind or deaf or with microencephalopathy. HIV is a concerning one. They are in the Panhandle District alone this year, I believe I've had 6 or 7 new diagnoses compared to 2 or 3 per year the previous 2 years, respectively. A lot of this is because there's more access to free testing. And we know that HIV can sit dormant 10 to 20 years, although the mark outside of 10 years are generally outliers. This is a graph of descriptive epidemiology statistics that show the majority are men still, and specifically men who have sex with men. But the cases of heterosexual contact is increasing. And a lot of this they believe, is due to the availability of dating apps, which some are mainly known for being hookup apps. So people on those apps and who use those apps often submit themselves to a lot more dangers. We see that it's also the prevalence that it shows here in Idaho, that it's more white, but I think you have to take consideration of the general demographic of Idaho as a whole is more white, because generally across the boards, across the nation, it is more prevalent in African Americans and Native Americans and Alaskan Natives, and also with Hispanic. Differences in new HIV diagnosis by gender, as you see, men have a greater propensity. Transmission, men who have sex with men are still at a higher rate, but heterosexual contact, as we mentioned previously. And part of our investigation that we do is a risk assessment. When we will speak with somebody who's newly diagnosed, we'll ask questions that determines their risk. Do you meet people online? Where do you like to have sex? How many sexual partners have you had in the last year that were anonymous? Have you had multiple partners? And have you had a partner that you know used to be an IV drug user, or who possibly was a male who had sex with another male at some point in the last 10 years? And actually, when we do HIV investigations, we need to go back 10 years to help identify some of their sexual contacts if they remember them during that time. And we also ask them, we do contact tracing to find out who they are, because these people need to be on PrEP if they're still currently having sex with this individual, which is a pre-exposure prophylactic, and it's offered free at the health districts and at many infectious disease docs. And also we need to let the person know, the case know that's newly affected, that in the state of Idaho, if you knowingly, maliciously infect somebody with HIV, knowing that you have it and you don't tell them, that is considered a felony. A couple things that we need to be consider when notifying people, especially if they have a spouse that they've been married to for some time, especially, is the possibility for domestic violence. And so fortunately, we have a nonprofit locally here in town, NIAC, that happens to have a lot of resources, including a social worker that can get in contact with them and help them, even sit down with them to break the news. There's also a notification system for all STIs that you can go to a website, and it gives out an anonymous text to all of their sex partners that says, hey, in the last so many years or whatever, you possibly could have been exposed to somebody with a sexually transmitted infection, and it won't release their name. So here are the new HIV diagnosis that you see by race and ethnicity. Black, African American is the highest, and Latino and Hispanic is second. And there are certain things that keep them from getting treatment, and a lot of it is the HIV stigma. Many cases in this state are actually prefer to go out of state for treatment because they're afraid of the stigma that they may receive from practitioners or their staff from people in the state of Idaho. Differences of new HIV cases diagnosis by age. So you see that for 13 to 34 accounted for more than half of new HIV diagnoses in 2020. And if you figure that back, a lot of that may have stayed latent for 10 years. It's not uncommon for 15-year-olds to be sexually active these days. So that would account for the 25 to 34-year-olds. Chlamydia. So by far, this is the most prevalent disease and the most easy to treat. Here are some descriptive statistics that I've gathered for the health district over the last 5 years. And this shows that if you look at September in 2021, we had a drastic increase of 124 cases. So this is where an epidemiologist would try to find a cause for this. Well, if you look at the year before, that's when the full year of the pandemic hit. Schools went virtual, colleges went virtual specifically. But in September of 2021, most of them decided to come back in person. So that is where you see a lot of sexual promiscuity in adolescents of that age, and a lot of substance use during that time too, which will lower their inhibitions and possibly not think about sleeping with several people or not using contraception or protection. So chlamydia, the rates amongst women, 15 to 44 by age group, and this is from 2011 to 2020, and you do see them generally going down. And a lot of that is believed because of primary intervention, which I will talk about soon. Gonorrhea. So this deals with the original, if you will, bug and the superbug, the drug-resistant gonorrhea. Cases of gonorrhea have increased over the last several years, and you see it specifically going up since a low in 2009. This is the antibiotic-resistant gonorrhea, and that talks about the resistance that has been shown for the MIC levels, and it's shown more resistant to azithromycin. So since the 2020 guidance says that it is still treatment, preferred treatment is an IM injection of 500 milligrams of ceftriaxone. Hepatitis C. This, by far, the most common vector for transmission is IV drug use and sharing needles. A good way to abate that is by having a needle exchange system. That has to be approved by the state and municipalities, and that's not approved in Idaho at this point, although NIAC does go around because they're a nonprofit. They have a mobile bus that goes around to our different counties and does needle exchange. The thing is, the good thing about having a needle exchange is that you're able to get people in to see or to have contact with some sort of a public health practitioner. And at that point, they can be introduced to, if they want treatment. The majority of people that have chronic disease of substance use disorder want to get clean, but they just can't. Maybe it's out of their reach because they can't afford it. Public health officials can help them apply for Medicaid, can help find treatment centers that will accept them. So these are the reported cases of acute hepatitis C infection. By far, the hepatitis C infections that we investigate as epidemiologists are chronic cases. If it's somebody that's in their teens to mid-30s, we will look at, before we call them, to determine if it's acute, we will look at their electronic medical records. We will look at their aminotransferase levels to see if their ALT is higher than their AST, which is indicative of a viral liver infection. We also looked at their symptoms and their progress notes and their H&P, see if they have a history of it that maybe they were not treated for before, and see if they do have the symptoms that are of acute Hep C. By far, we see more acute Hep B, although that can be chronic as well. And of course, Hep A, all Hep A is acute. And with this, so our epidemiologists, and we do this with all diseases, is we do look at, before we do the contact tracing and talk to the case themselves, the patient, we will look at the EMR. So all of my epidemiologists contact and disease investigators do have some clinical experience, do have academic knowledge, anatomy and physiology, biology, microbiology, chemistry, biochemistry, familiarize themselves with lab values and what that might mean physiologically, that person might present with. And so they use those hard sciences along with the soft sciences of the social cultural considerations that they have to consider when they are talking with people within different races, within different cultures. So having some academic knowledge of anthropology is really important as well. So it's both a mixture of the hard and soft sciences. So the rates of reported acute hepatitis C infection have gone up, of course, from 2009. And a lot of it is because the increased homelessness, it's believed, mental illness that is untreated, and it is treated by illicit drugs and needle sharing. Reported rates of acute hepatitis C infection by race, as you see up there, it's higher with the American Indian and Alaskan Natives. And one of the things to remember that we need to remember about people of Asian descent, which Native Americans are, is that they physiologically, they lack or they have lower amounts of an enzyme that assists in breaking down alcohol, specifically alcohol dehydrogenase 2. So alcohol has a more detrimental effect on the body. And it can act as a poison, a real poison for them. Here are the breakdown by gender, by sex and age. Males you see, this is for newly reported chronic hepatitis C infections. So a lot of the chronic ones will still show up. Maybe they were diagnosed, some will say they were diagnosed in 2005, but they couldn't handle the treatment because the treatment at the time was interferon, which has really bad side effects, and they would just stop their treatment. But now there's a lot better treatment that's out there, it's available to them that we can introduce them to and get them involved in those resources to get these levels down. So our mitigation strategies that we use as epidemiologists, by far for STIs, it's primary intervention where we focus the most, and that is education to our high school students, our freshmen. We go out to high schools, or they invite us in for their health classes, and we go out, we give an hour, 50-minute or an hour presentation that talks about the different sexually transmitted infections, where they can go for treatment, how they are treated, and how they can use protection. The use of condoms, the use of female condoms, and dams for that case. Another one is condom distribution. Can't do that at high schools in this state, but we can distribute them, and this is free. We have just tens of thousands of condoms that we give away every year. Give them away the most are to OBGYN and pediatric practices, as well as private practices. And we will even forecast when there is likely to be a drinking holiday that comes about, St. Patty's Day, notorious for that. And we will go to the bars downtown, and we will give them free condoms. We don't require them to take them, of course, but almost 100% of them take them. And they put them in bowls up on the bar top for people to use during that time. There is free testing that's available. People can order a test and have it mailed to them. Right now, they have to pay for it, and that is from letsgetchecked.com. But Idaho is trying to initiate a free program for HIV testing where they can go online, give their address, they get the test, they send it in for a PCR test. If it's reactive, they automatically try to do a differential test with that, and they do that with a blood stick, like a capillary fill. And then they send the results back to them, but if they're positive, they will have them do a video interface with a public health department, a practitioner who talks to them about coming in, do you need transportation, and The one thing that is hung up on with the states and practitioners is that, the standard of care is to redo the tests, of course, when they come in. And the state is saying, well, that's not an incentive for them to go in if they have to do the test all over again. But that is a standard of care. So we'll see how that goes in the coming year. Point of service care is important because, especially with chlamydia and gonorrhea, they will come in and they'll test reactive on a rapid test, especially for like gonorrhea, or they'll look at the chlamydia under a microscope and be able to see it, and they can give them their pills right there. And they provide partner services. They provide pills for their partners, and they'll either write a script for them or they will just send them out in a little packet of pills. These are for your partner. How many did you have that you may have been exposed, and give it to them. And they can remain anonymous with that. With syphilis, they come in, they get a rapid reactive test. They will get treated right away with 2.5 million units of syphilis, IM in the buttocks. And then we will wait until we get their RPR ratio back. If the RPR is high enough to warrant 2 more visits, then they will come back at 7 and 14 days. And it's important that they get back within that treatment time and they stay with the penicillin G, the bicillin. You can't mix doxycycline in with that to replace because the new guidelines say that they have to start over their treatment completely. And there's a 2-day window at that 7 days. If they miss that 2-day window, they can't come in within that 9 days. They have to start the treatment all over again. And a lot of places do not carry, a lot of like family practice offices do not carry the penicillin G. So they'll refer them to us, and we will treat them, and we do it on a sliding scale or for free. And something else about what we need to discuss about HIV treatment is some people say, well, I can't afford those medications because they're expensive, but the Ryan White Act of 1996 makes it affordable and available to anybody, even if they go out of state. So there's always an avenue for care. Stigma reduction, which is really a big reason that a lot of people do not seek care. It's a lot of reasons that a lot of high schoolers don't come in and grab a free bag of 10 condoms off of our counter in the public health district because they're afraid of the stigma that's associated with maybe them having sex. But if you can imagine, being diagnosed with a sexually transmitted infection can bring more stigma to that as well. So our practitioners are working on ways, and we work with stakeholders and practitioners to help reduce that stigma. And then investigations, which we talked about lightly, but this is really important. And a lot of times, so with chlamydia, we generally don't talk to the patient themselves unless we see a trend with them on their disease registry reports where like every 3 months they're getting chlamydia all over again. So we may call and talk with them about the conditions that they may be putting themselves in. Some are sex workers and their clients don't wear condoms. Some don't receive treatment, or they don't return for treatment, or they go to a place that doesn't offer that point of service care. And those ones that we will call and talk with them about, we now investigate all gonorrhea. And we enter in the treatments of the drugs that they were received into the NBS program so that NIH and the CDC can track what they were treated with to help identify drug-resistant strains that come about from that. And there's increased gonorrhea with dissemination. And somebody will go in, they don't have symptoms of gonorrhea or an STI. They'll go in for knee surgery, and then they'll get a localized infection with green pus. And they'll have that sampled and cultured, and the doc will come back and says, you have gonorrhea in your knee. and they'll say, isn't that a sexually transmitted disease? It is. And then they will be treated for, and their partners treated for, that sexually transmitted disease. And that could even go as far as disseminated as having it gastric, which can only be identified by blood cultures. So those are the investigations that we do. So we help find the source of it. I mean, there's a lot of source of ailments from substance use disorder that haven't even been mentioned, social, cultural, theft, homicide, increased incarceration rates. Those are all areas that are tertiary effects of substance use disorder in particular. And I appreciate your time listening to me today, and I hope you have a good day. Thank you.